Okay, let's deal about chest pain today and how to deal with chest pain in our emergency department. So our initial goal should be to rule out any life-threatening condition. Okay, if it's a life-threatening condition, it might crash our patient or patient might die within minutes to hour if we do not stabilize the patient. Okay, and so acute coronary syndrome comes first. After that, aortic dissections. Okay, aortic dissection, pulmonary embolism, tension pneumothorax, tension pneumothorax. Okay, pericardial tamponade, pericardial tamponade, and esophageal rupture. These are the few things, okay, six things which should be ruled out at first, and we have to deal with the patient. If we think our patient has chest pain due to any of these things, okay, so during initial assessment we have to look for airway, breathing and circulation. We have to look if the airway is intact or not. Nasal airway, the air can be taken from mouth as well. Mouth, if there is anything in our mouth, we have to remove that. If nose is blocked, we have to clear that. Okay, it can be due to secretion, it can be due to food particle, anything. Okay, if and then we have to look for breathing, if the patient is breathing spontaneously or not. Okay, spontaneous breathing is there or not. After that, we can look that by our nasal flaring is there or not, nasal flaring, or if there is chest rise or not, chest rise. Or if you are in doubt, you can put some spatula or something like anything in below the nostrils to look for the mist formation. Okay, if there is mist formation, then we can know the patient is breathing. Okay, after that we have to look for the circulation. Basically we look for BP and pulse and circulation. If BP is not good, or if the patient is in shock, we have to treat that first. Okay, if any of these things not good, we have to deal with that first. Okay, after that we have to record BP, both hand. Okay, in both hand we have to record BP in chest pain, remember that. Pulse, for pulse also we have to look for the rate, rhythm and synchronization. Radial synchronization is there or not, radiofemoral synchronization is there or not. We have to look for SpO2, respiratory rate and temperature. After that we have to take a focused history. Okay, because it matters, and it will help us to go deeper to know which can be the cause for the patient. Okay, site, it can be central cause might be due to chest or cardiac cause. Peripheral or lateral chest pain can be due to our pericarditis. Chest pain, pericarditis or cardiac cause is mostly central. Peripheral lateral might be due to our pleural cause. Okay, pneumonia, pleural, pleuritis, musculoskeletal pain can be peripheral. Certain type of chest pain can be due to aortic dissection. Okay, aortic dissection, pulmonary embolism and pneumothorax can be there. Or in gradual cause of chest pain, it can be due to angina. Remember, in angina the chest pain gradually increases. In stable angina it will last for less than 5 minutes, and unstable angina can be more than 5 minutes. Okay, and anginal pain can be gradual, or pericarditis pain can be gradual. Okay, and after that we have to look for the character. Okay, pressure or heaviness in the chest can be due to ACS, okay, acute coronary syndrome, and tearing type of chest pain can be due to aortic dissection. Pleuritic type of chest pain can be due to pleural effusion or our pulmonary embolism. Pneumonia, pericarditis can be pleuritic type of chest pain, pericarditis. Okay, radiation to left arm or jaw can be due to our ACS. Okay, and associated symptoms. Okay, dyspnea, diaphoresis or sweating. Basically nausea can be there in acute coronary syndrome. Okay, syncope can be there in aortic dissection. Okay, and timing timing duration more than 20 minutes of chest pain can be due to MI. Okay, acute coronary syndrome. And exacerbating and relieving factor, now pleuritic type of chest pain which increases on respiration can be due to pericarditis. Okay, and our which is relieved on leaning forward. Okay? Leaning forward. Okay, and severity we'll look with the Penn scale. Okay, after that we have to know risk factor, which for ischemia, if age is more than 40, male, smoker with hypertension, diabetes, dyslipidemia, history of coronary artery disease in family, recent immobilization, surgery, malignancy. Okay, malignancy can be there in this pericard, this our embolism. Okay, pulmonary embolism. Okay, after that we have to go for focused physical examination. Okay, focused physical examination, look for diaphoresis, pallor, anxiety. After that we have to look for the vitals pattern matters, to know the disease pattern heavily matters. Okay, if there's hypotension, muffled heart sound, and increased JBP, this can be seen in tamponade, cardiac tamponade. Okay, if there is asymmetrical BP or pulse or BP can be there in aortic dissection. Remember, in aortic dissection, the pain is severe, sudden, tearing type in the chest or back. Okay, that's radiated to back. Central chest pain that's radiated to back, and there is significant difference in BP between two hands. There more than 20 mmF of systolic BP difference between two hands. Okay, and tachycardia and hypoxia can be there in pneumothorax. This pattern helps us to know the disease. Okay, if there is a new murmur can be there in MI. MI might cause MR or AR. Okay, if there is rupture in papillary muscle dysfunction, rupture that can lead to new murmur. Okay, in aortic dissection as well there can be AR. Okay, new onset AR. Okay, pericardial rub can be there. In respiratory system analysis, if there is decreased air entry, hyperrhinosis, then it can be due to pneumothorax. Okay, pneumothorax. If there is crackles, can be due to left ventricular failure or pneumonia. After that, we can look for the chest wall. If there is local tenderness, that can be due to musculoskeletal or costochondritis. Okay, musculoskeletal or costochondritis. After that, we have to, after focus history examination, taking ABC, taking vitals, we have to go for investigation as well. Within 10 minutes of arrival of the patient, we have to do ECG. Okay, and we have to look for any signs like ST elevation or ST depression, which new onset this T wave inversion or hyperacute T wave, that helps us to diagnose acute coronary syndrome. Okay, and cardiac biomarkers, like if there is readily available high sensitivity troponin I or simple troponin I, we have to do that. And remember, we have to repeat it after 4 hours, because within first 4 hours that can be negative as well. Chest X-ray can be done to rule out pneumothorax, and we can also see widened mediastinum in aortic dissection. Bedside echo is always useful to look out the regional wall motion abnormality for MI, and we can also find out pericardial effusion or tamponade. Okay, tamponade. Okay, and ABG SpO2 to look for any hypoxia, sign of hypoxia is there or not in case of our pneumothorax itself, or pulmonary embolism. D-dimer CTs can be done only if they are suspected by Wells score. Better to find Wells score, and if Wells score tells us to do, then we can do CT pulmonary angiography. And CBC, renal function, electrolyte, these are baseline tests. Okay, this will not tell us any disease. Okay, risk stratification can be done for ACS with using Hart score or Grace score, you know. This basically, these are the two scores which will help us to decide whether we can discharge the patient or we have to admit that patient. If the Hart score is 0 to 3, that means it's a low risk, we can discharge the patient. If it's more than 7, it's high, we have to do repeat the test. Okay, Hart score basically comprises of these things like in history, ECG finding, age, risk factor, troponin. Okay, according to different types of category, different number is there, and we have to calculate Hart score or Grace score. Grace score is generally for mortality prediction. After that, we make a diagnostic framework, right? After history examination or investigation, if we suspect cardiac ischemia, that can be STMI, NSTMI, unstable angina. Okay, with pressure, exertional chest pain that is radiating to left jaw or left shoulder with elevated troponin. If we suspect non-ischemic cardiac pain, like in case of pericarditis or myocarditis, it is pleuritic type of chest pain which is positional. This pericarditis pain will relieve with leaning forward. Okay, and there is diffuse ST elevation in pericarditis. Okay, and in vascular pain like aortic dissection, there is a central type of chest pain, sudden tearing type of chest pain that is radiating to back. Okay, in pulmonary embolism, there is a rise in D-dimer, but the history of malignancy or prolonged immobilization is important. This pulmonary embolism itself. Okay, in pulmonary type of chest pain, like in case of pneumothorax, pneumonia, or pleuritis, the pleuritic type of chest pain occurs. Okay, in pneumothorax, there is decreased breath sound, hyperresonant lung field. Okay, and X-ray can be done to know it's a pneumothorax or not. Pneumonia, basically fever, chest pain, cough, purulent type of chest pain will be there, and other type of chest pain, gastroesophageal related like GERD, spasm, costochondritis, even anxiety can cause chest pain. Okay, and these are little bit difficult to have a strict diagnostic criteria, and these are generally, this type of chest pain is generally we rule out other thing, and after that if there is no other thing, we try to localize, or we try to say this type of chest pain might be due to this thing, and we have to search for this simple diagnosis as well. So now going towards the immediate management for all patient. Okay, for all critically ill patient, oxygen should be given if SpO2 is less than 90%. Okay, we have to have IVSS. We have to have cardiac monitor and pulse oximetry. Okay, we should have ECG monitoring of the patient. After that, if ACS is suspected, okay, from history, ECG finding, or troponin rise, then immediately we have to give aspirin, clopidogrel, and nitroglycerin sublingual if we have, or otherwise morphine can be given. Remember, for GTN or nitroglycerin sublingual, if we suspect right ventricular type of ischemia or right ventricular this arteriary or inferior MI, or if the patient is hypotensive, then we cannot give that nitroglycerin. Morphine if there is severe type of chest pain and high intensity statin like atorvastatin 40 to 80 mg or rosuvastatin 20 to 40 mg can be given. Okay, and we have to call cardiology for PCI or thrombolysis. Okay, and remember, dole to balloon time should be less than 90 minutes. Okay, you have to remember two things. Okay, if you are in a central where there possibility of PCI, or if the PCI can be done within 120 minutes or 90 to 120 minutes, um, then you have to rush for PCI. Okay, but if you cannot reach within 90 minutes, if your patient cannot reach within 90 minutes to PCI capable center, then you have to give thrombolysis within 30 minutes. Okay, you have to do thrombolysis within 30 minutes, and then send the patient to PCI capable center. Okay, if you suspect PE, then you have to risk stratify the patient. Okay, you have to risk stratify the patient into if the patient is normotensive with normal right ventricle, non-right ventricle, or if there is normotensive plus there is right ventricular hypokinesia. Okay, hypokinesia is there, or if there is hypotension. Okay, in both of them the patient is normotensive, normotensive. Okay, normotensive or normotensive. Okay, and there is no right ventricular strain, normal tension, then we have to give secondary prevention only. Okay, if our patient is normotensive, there is if our patient hypotensive, okay, hypotensive patient, then we have to give primary therapy. Primary therapy is basically two things. If we can remove that embolus, we can do embolectomy, then we have to do that. Okay, and by surgical or catheter guided embolectomy should be done. If otherwise, anticoagulation plus thrombolysis should be done. Thrombolysis, anticoagulation plus thrombolysis. If there is person is hypotensive, if there is normotensive and no right ventricular strain, then secondary prevention itself. Secondary prevention can be done by inferior vena cava filter or anticoagulation alone. Okay, and in this middle normotensive, no right ventricular hypokinesis there, then it's individualized. We can go either to this side or this side. Okay, and if we think, okay, it's here basically, and if this pneumothorax suspected, we have to needle decompression. Okay, if tamponade suspected, we have to pericardiocentesis. Okay, now going towards the summary. Okay, rapid ABC and vitals will be taken. Focus history and examination is must to detect the red flag sign. After that, we should do ECG, troponin, chest X-ray within 10 to 15 minutes. Okay. After that, identify and exclude 6 killers: acute coronary syndrome, pulmonary embolism, dissection, pneumothorax, tamponade, and esophageal rupture. We have to stabilize the patient. We have to give specific management. Okay, and if no life-threatening causes, manage as per etiology like GERD, any other musculoskeletal pain, then we have to deal with them accordingly. Okay, and document and risk stratify, and after risk stratification only you can discharge or dispatch to patient to ward or ICU. Thank you. These are the key reference. Harrison, Davidson, Toronto Notes is very good, up to date guidelines. Okay, remember last moment clinical pulse. These are very important thing. Pain reproducible on palpation does not always rule out ischemia, but if you can pinpoint where the pain is in your chest, and then that is not ischemia. So pinpoint is not ischemia. Okay, up to 5 to 10% of ACS have normal initial ECG. You have to repeat it within 15 to 30 minutes. Troponin elevation alone is not MI. Okay, remember, troponin elevation itself is not MI. You have to look for the risk factor as well, and you have to know other etiology like myocarditis, renal failure, sepsis. These all can have certain level of troponin increase, even pneumonia. Okay, in pulmonary embolism, these all cause increase in troponin. Okay, never give nitrates if you suspect right ventricular infarction or severe aortic stenosis. Always compare BP in both arms if you suspect dissection or to suspect dissection itself, and this is very simple thing to have BP on both hand initially when the patient comes. Thank you, thank you this much for today. Love, love, love.